Hi everyone. Now let's have some insights regarding pain management in labor. Most women expect and experience pain in labor and childbirth. Pain is a subjective experience and it is whatever the woman says it is for her. Labor pain is often described as the most intense ever experienced, and in many cases it is an aspect of childbirth most feared by the expectant mother. Physical, psychological and cultural factors plays an important role in the woman's response to childbirth. Although the intensity of pain experienced varies a great deal from one woman to another. My name is Ruth Kesia. I am working as a tutor in Triple College of Nursing. So in this session, we are going to learn how the pain of labor differs from other types of pain and sources of labor pain, factors influencing the woman's experience of labor pain, compare the non-pharmacological interventions to manage labor pain and explain various relaxation techniques that help a woman cope with the labor pain and differentiate between analgesia and anesthesia. And we are going to learn about the advantages, disadvantages of the opioid administration and compare methods of regional anesthesia, explain major complications associated with spinal and epidural anesthesia, and discuss the reason general anesthesia is risky for a woman and her fetus. Now, what is labor? Labor is a process by which the fetus in the placenta leaves the uterus. Delivery can occur in two ways, vaginally or by a cesarean section. Now let's see about some of the signs of labor. Some women experience very distinct signs of labor while the others do not. No one knows what causes labor to start or when it will start, but several hormones and physical changes may indicate the beginning of labor. Some of the signs and symptoms that impending labor are lightening, passing of the mucus plug, contractions, rupture of membranes, effacement and dilatation of the cervix. These are the signs of the labors. I repeat it: lightening, passing of the mucus plug, contractions, rupture of membranes, effacement and dilatation of the cervix. Now let's see about the characteristics of pain. That is, as I said earlier, pain is a subjective experience. It is a purely subjective experience and it is whatever the woman says it is for her. Labor pain is often described as the most intense ever experienced and in many cases the aspect of the childbirth most feared by the expectant mother. So some of the characteristics are unique and it is unique pain different from other types of pain. Usually the pain is a warning sign of injury, but in this pain it is not an injury. Okay. And increased intensity desired and positive. The greater the intensity is associated with the approaching birth. So in other cases, for example, if it is a trauma, so increased intensity in pain is not a good sign. But when you take a labor, the increased intensity and the duration is considered as a positive. It is a good sign of the labor. And it occurs in a predictable pattern, begins without warning, but once established is predictable. So these are some of the characteristics of the labor pain. Now we'll see about the causes of pain in labor. Stage 1. So in the first stage, the pain is occurring due to the dilatation of the cervix, hypoxia of the uterine cells during contractions, and stretching of the lower uterine segment and pressure on the adjacent structures like uterine ligaments. So initially the contractions are felt in the lower back and then progress to the lower torso in the back and to the abdomen. So this is the reason for the causes of pain during the first stage of labor. So this is the causes of pain during the second stage of labor. So as the fetus descends down, the increased flexion and descent takes place. This is what happens. There is distension of the vagina and the perineum, compression of the nerve ganglia in the cervix and the lower uterus, pressure on urethra, bladder, rectum during the fetal descent, and traction of the stretching of the perineum. So all this contributes to the pain during the second stage of labor. So those are all the causes till the second stage of labor, causes of pain till the second stage of labor. But during the delivery, there is often a decrease in pain. Although many women describe the sensation of a stretching, splitting or burning. Most third stage pain results from contractions and cervical dilatation as the placenta is expelled. After the third stage, anesthesia is needed primarily for the episiotomy repair. Now let's see about the perception of pain. The way in which an individual perceives and reacts to pain is affected by many different factors. First is cultural and social factors. Some cultures expect fortitude in suffering while others encourage expression of feeling. The perception of pain may be altered if the woman has experienced pain and hardship previously. So if the pain she has experienced previously, this is not going to be new for her. And next is fear and anxiety. This will heighten the individual response to pain, fear of the unknown, fear of being left alone to cope with an experience such as labor, and fear of failing to cope well will increase the anxiety. A previous bad experience will also increase the anxiety. Next is the fatigue. The woman who is already fatigued by several hours of labor, perhaps preceded by a period when sleep was disturbed by the discomforts of late pregnancy, will be less able to tolerate the pain. Next is personality. The woman who is naturally tense and anxious will cope less well with the stress than one who is relaxed and confident. And next is expectations. The woman who is realistic in her expectations of labor and about her likely response to it is probably the best equipped, as long as she feels confident that she will receive the help and support she needs and is assured that she will receive appropriate analgesia. So the realistic expectation of the woman's during labor should be met in order to get a good perception regarding the management of pain during her labor. Next, we see about the principles of pain relief during labor. So, according to this criteria, we must put other forms of pain relief, whether it is a pharmacological or non-pharmacological pain relief. It is according to this criteria. The first is women are more satisfied when they have control over the pain experience. And this means if we load a syringe or a continued infusion in Western setups, in modern hospitals, they used to give to the woman. So when she is getting contractions, the woman, the mother itself, she will itself inject the injection, and she will feel more comfortable during the labor. This is what it means. A woman is more satisfied when they have control over the pain experience, rather than the midwife is administering the medicine in a larger amount between longer intervals. This is more satisfied for the woman. And next is the caregiver commonly underrate the severity of the pain. So as I said earlier, the pain is purely subjective. So whomever is seeing that labor pain, they will not be able to understand the pain completely. And women who are prepared for labor usually report a more satisfying experience than women who are not prepared. Okay, so the prepared, the labor class should be taken for the antenatal mothers to be prepared for this experience. Next is the pain management techniques in labor. The first is non-pharmacological pain interventions. So in this we are going to see this one by one: the gate control theory, acupuncture, acupressure, therapeutic touch, transcutaneous electrical nerve stimulation, bathing, showering and warmth, positioning, hygiene and comfort. Now let's see this one by one. So according to this gate control theory, the pain is the result of interactions between several specialized neural systems. This theory postulates that a mechanism in the dorsal horn of the spinal column serves as a valve or gate that can increase or decrease the flow of nerve impulses from the periphery to the central nervous system. So now you see the diagram, this is look like a spine, right? The cross section of spine. And there is a structure called dorsal horn in this spinal column. So this is the dorsal horn and it is considered as a gate. Okay, through this gate only the perception of pain from the periphery is transferred to the brain, that is central nervous system. So if the gate is open, the brain is going to perceive pain, and if the gate is closed, it is not to perceive, the brain and the central nervous system is not going to perceive any pain, okay, from the peripheries. So not only the gate, even if the gate is open also, the size of the nerve fibers which transmits the impulses also influence this pain, because see, this is the smaller nerve fibers and this is the larger nerve fibers. So the pain which is transmitted through this nerve fibers, the intensity will be increased. The pain impulses which are transmitted through the smaller nerve fibers, this intensity will be decreased. So the size of the nerve fibers also influences this gate control. This the size of the nerve fiber also influences the pain which is perceived by the central nervous system. So if there is a pain in our body, the pain perception and the response will activate this gate system, and it will influence our psychological process, including experiences, attention and emotion. The gate control theory, as it applies to obstetrics, has vast implications. It suggests that pain can be controlled by tactile stimulation and can be modified by activities controlled by the central nervous system. These include back rub, sacral pressure, suggestions, distractions, and conditioning. Abdominal effleurage, a specific type of cutaneous stimulation, is used before the transitional phase of labor. It consists of light abdominal stroking. It is used in the Lamese method of childbirth preparation. It is particularly effective in relieving mild to moderate pain, but is ineffectual for intense pain. In the application of deep pressure over the sacrum is more effective for relieving back pain. So this is about the gate control theory. Next we'll see about the acupuncture. Has been widely used in Orient for many years, and there is increasing evidence that it may be an effective tool during labor. In some cultures, women have pressed combs into the palm of their hands to reduce the pain of contractions. Similarly, acupuncture involves the insertion and rotation of needles on specific points of the body, which is thought to produce analgesia and sedation through the release of beta endorphin. However, acupuncture is an invasive technique that may cause infection. Next, we'll see about the acupressure. Acupressure is also one of the non-pharmacological methods of pain relief during labor, and it has also been long used in the Orient. Acupressure is thought to activate the release of endorphins in the body. It is defined as finger pressure or massage over pain prevention points or acupressure points, and it is another form of touch therapy. Proponents of the gate control theory speculate that the acupressure's pain relieving qualities are based on blocking the gate at the level of spinal cord. This technique is now taught in many childbirth education classes in the developed countries. Acupressure may be used to alleviate some of the common discomforts in pregnancy, such as dizziness, faintness, headache, or sciatic nerve pain and leg cramps. In labor, acupressure is used as a part of a pain control routine that includes relaxation, concentration, and rhythmic breathing. Contraindications to this technique include any site where there is red, swollen, broken, or infected skin, and selected points that should not be used during pregnancy because of the potential to induce labor. Next is yoga and meditation. These are claimed to have calming effect, assist the mother in becoming tuned to her body, and give a focus for distraction from pain and tension. Next is therapeutic touch. Throughout the history, people have been used touch as a means of calming a person. Now, according to the researchers, there is evidence of an actual transfer of energy taking place in some forms of touching, as evidenced in muscle relaxation. Therapeutic touch offers several advantages. No device are required, no physician orders is needed, the technique is non-invasive, and it incurs no cost since the technique is incorporated into nursing care. Indeed, there has been extensive research by nurses into the background and application of therapeutic touch, which was originally described by a nurse, Dolores Krieger. The technique has no religion basis and requires only the conscious intent of the healer. Therapeutic touch may offer a powerful means of enhancing relaxation, reducing anxiety, and controlling pain. It can be of help to couples increase their communication and alleviate discomforts of pregnancy. During labor and birth, it is used along with breathing and other relaxation strategies. And in the early months of parenting, it is frequently used as a means of calming a crying baby, relaxing a distraught parent, or helping a woman through postpartum blues. Therapeutic touch can benefit not only the client but also the healer through enhancing her sense of inner harmony, well-being, and relaxation, enabling her to cope while healing. Touch is a means of making coping skills more powerful and effective. Next is transcutaneous electrical nerve stimulation. This method of alleviating pain by electrical nerve stimulation generally requires the services of a physiologist or other professionals. Although TENS is widely used outside the obstetrics, its use in labor is questionable. It may interfere with continuous electronic fetal monitoring since it must be applied constantly to gain relief. Moreover, it is most effective only if introduced before crisis. Next is bathing, showering, and warmth. During the early stage of labor, bathing or showering may afford a measure of pain relief for the woman. No physician orders is needed for showering. Whichever method is employed, the midwife should remain in close attendance to avoid possibility of accidents and hypothermia. The midwife must also be alert to the mother's need for bodily warmth in cold climates and should provide blankets as needed to keep the room temperature at a comfortable level as appropriate. Next, we'll see about the positioning in labor. The midwife should encourage the laboring woman to assume whatever position she finds most comfortable. However, any position used during labor and delivery should facilitate the alignment of the presenting part to the axis of the pelvis and should encourage the mother's effort towards accomplishing delivery. Women may require help to find positions which are comfortable for them. Leaning forward with the arms resting on a convenient table or shelf during a contraction may help the woman cope with the backache. A rocking chair provides a soothing rhythmic distraction during contractions. The motion the motion probably encourages the release of endogenous opioids, and most rocking chairs give good support to the back. A reclining chair also gives good support, but a recommended position should be avoided because of the risk of aortic cable occlusion. Birthing beds and chairs are designed specifically for women in labor and most are very versatile. Ideally, they are used for delivery only and the woman is encouraged to walk about and use alternative position during the first stage of labor. An alternative position may be described as any position other than recumbent, semi-recumbent, or sitting on the bed. The woman follows her natural instincts and find a position and movements such as pelvic rocking which feel right for her, making use of gravity to assist the descending of the presenting part. An upright or kneeling position, as in the picture, an upright or kneeling position also allows maximum give of the pelvic girdle, whereas sitting causes pressure over the sacrum and coccyx. Any woman in normal labor may benefit from freer mobility. Next is hygiene and comfort in labor. The woman in labor will become very hot and will sweat profusely. If she is able, she will prefer a bath or shower. If the woman is not able to get up, she will appreciate frequent sponging, particularly of her face and neck with cold water. A clean, cool gown will be appreciated and a fan is comforting. Her mouth will feel much fresher if she can clean her mouth or have a mouthwash. Care of bladder and bowels is an important aspect of the mother's comfort in helping the woman's laboring woman to achieve pain relief, the midwife should focus on the body's natural resources and should emphasize supportive pain management techniques for labor and childbirth. Next, we'll see about the advantages and disadvantages of the non-pharmacological intervention. So, whatever we have seen till now, that is gate control theory, acupuncture, acupressure, yoga and meditation, therapeutic touch, transcutaneous electrical nerve stimulation, bathing, showering, warming, positioning, hygiene and comfort. These are the non-pharmacological interventions for the pain relief during labor. So the advantages are non-invasive. They are non-invasive. It can address emotional and spiritual aspects of the birth, protect women's sense of control over pain. The disadvantages are many of the interventions require special training and or practice before birth. These methods are not effective for every woman. Next, we'll see about the pharmacological interventions. So till now we have seen about the non-pharmacological interventions. Next is pharmacological. So this non-pharmacological intervention is of two types: analgesia and sedation and anesthesia. So the analgesia, the use of medication to reduce the sensation of pain. Sedatives given to promote sedation and relaxation. Opioids given to promote analgesia during labor. And anesthesia, the use of medication to partially or totally block all sensation to one area of the body, and it can be of three types: local, regional or general. So as I said already, in analgesia and sedation, the sensation of pain is only reduced. But in anesthesia, if you see, the sensation of pain is totally blocking. It is totally blocking all the sensation of the pain in the particular area of the body, and it is of three types: local, regional or general. So these are the commonly used narcotic analgesics for the analgesia and sedation. The first drug is meperidine hydrochloride. It is widely used. The commonly used dosage is 25 milligrams IV or 50 milligrams IM, and it can be given Q4 hourly. The effect of the mother will be, it is an analgesic and feeling of well-being. The effect of the labor, it promotes relaxation and it aids in cervical dilatation or relaxation. But if it given early, it can also slow the labor contractions. In effect of fetus or newborn, it should be given 3 hours before birth to avoid respiratory depression and decrease in the heart rate. The other drugs are nalbuphine, butorphanol, morphine sulfate, fentanyl. Morphine and fentanyl are the opiate analgesics. All these drugs can cause respiratory depression in the fetus. So till now we saw about the different types of analgesia and sedations. So this is about the anesthesia. The first type is lumbar epidural block. The drug used is marcaine or norepinephrine. Usual dose is administered first stage of labor with continuous block. Anesthesia will last throughout the birth and injected between L3 and L4. Effect on the mother, rapid in onset in minutes and lasting for 60 to 90 minutes, and loss of pain perception of the labor, contractions and birth, and possible maternal hypertension. Effect on the labor progress, slowing of the labor can occur if given early. Pushing, feeling obliterated, resulting in possible prolonged second stage of labor. So the mother will not have the feeling urge to push because of this epidural block. Effect on the fetus may result in respiratory depression, may sometimes difference in the response in the first few days of life. The next type is pudendal block. It is a local anesthetic. It is given in the perineal region. The rapid anesthesia, the onset is rapid, and the effect on the labor and the fetus is non-apparent. Next is local infiltration of the perineum. It is injected before the episiotomy incision, and anesthesia is almost it is also immediate in onset, and the effect on the fetus and the effect on the labor is non-apparent. Next is general intravenous anesthesia. The drug used is thiopentothal. It is administered by IV by the anesthesiologist or nurse anesthetist. The onset of action is also rapid, And the effect of the labor is forceps sometimes can be required because of the abdominal pushing is no longer possible, because it produces a profound anesthesia. So as I said already, the anesthesia means it blocks all the sensations, so the mother will not feel any urge to push. So sometimes the forceps can be required for the delivery, and in fetus it results in infant being born with central nervous system depression. Advantages and disadvantages. Advantages are it increase an increased ability for the woman to cope with the labor, and the medications may be nurse administered. Disadvantages: frequent occurrence of uncomfortable side effects such as nausea, vomiting, pruritus, drowsiness, and neonatal depression. The pain is not eliminated completely. These are some of the disadvantages. And the nursing considerations are, when administering analgesic drugs, carefully and continuous observation of maternal respirations and fetal heart rate are mandatory, with the baseline FHR and maternal vital signs recorded on the monitoring strip. It means before administering the drug and after administering the drug, both the vital signs, the mother's vital signs and the baseline FHR should be recorded on a strip. The physician written order is checked and the drug is prepared and signed out on the narcotic sheet. I already told you that drug like fentanyl and morphine are some of the narcotics, so it requires double check. The woman's armband is checked, the woman is correctly identified, and she is asked again if she is allergic to any drug. The drug is administered by the route ordered. The medication, time, dosage and site of administrations are charted in the nurse's notes. Safety precautions include side rails, continuous observation for nausea and vomiting to prevent aspiration. While receiving analgesia, the woman should preferably be in an individual birthing or labor room with the environment free from sensory stimuli. She should be encouraged to empty her bladder before drug administration, and she should not be left alone. These are some of the nursing considerations. So earlier we saw the types of drugs used in the anesthesia. Now we'll see about the types of anesthesia in detail. First is local anesthesia. It is used to numb the perineum just before birth to allow the episiotomy and repair. Next is regional anesthesia. It involves blocking up a group of sensory nerves that supply a particular organ or area of the body. Next is general anesthesia. It is not used frequently in obstetrics because of the risk involved. Types of the regional anesthesia. They are pudendal block, paracervical block, epidural anesthesia, intrathecal anesthesia. Pudendal block, it is pain relief for birth. Paracervical block, it gives pain relief during labor. And epidural anesthesia, it gives pain relief during labor. Intrathecal anesthesia, it provides pain relief until the epidural begins to work. Now see about the epidural anesthesia. Injection of an anesthetic agent into the epidural space, it provides pain relief during the labor and delivery. So if you see in the picture, the yellow color stripes that is called the dura, and epidural means, epi means above. So epidural means the space above the dura is called epidural space. So the injection is given in this space, in this black space. So this is called epidural anesthesia. So in this epidural anesthesia, if the drug is given in a small amount, it relieves the discomfort of the uterine contractions. But if it is given in a larger dose, it extends the anesthesia to the vagina. An additional dose may be given to provide perineal anesthesia. Its advantages are that it can be given during the active labor, providing effective pain relief during uterine contractions and cervical dilatation. It also enhances the woman's rest, relaxation and ability to cope. However, it has several disadvantages. If given too early, it may slow the labor and may result in maternal hypotension and decrease in placental blood flow. The second stage of labor may be lengthened since the mother does not feel the bearing down sensation, thus possibly requiring a forceps delivery. It may interfere with the woman's ability to void and it may cause infection. In addition, the dura mater may be punctured, resulting in inadvertent spinal anesthesia. Some of the contraindications of epidural anesthesia are anticipated maternal hemorrhage, presence of local infection at the injection site, and if the woman has cardiac, pulmonary or central nervous system, this epidural anesthesia is contraindicated. So next we see about the spinal anesthesia. So this is the spinal space, that is the subdural space. So this is the subdural space. This is the dura mater, the line. So this is the dura mater, and then the space above the dura is called epidural space. So epidural anesthesia is given in this space. The spinal subarachnoid space. So in this region. So the epidural anesthesia, the spinal anesthesia is given in the subarachnoid space. So difference is, if you inject a needle in the epidural anesthesia, epidural space, there is no return back of any fluid. It is an just air-filled space. But in subarachnoid space, you know, there is the CSF fluid flows into this subarachnoid space. So if you inject a needle into the subarachnoid space, we can get the backflow of the spinal, that is cerebrospinal fluid. So that is a confirmation of subarachnoid space, and the spinal anesthesia given in the space. So the spinal anesthesia involves the injection of local anesthetics directly into the spinal fluid, providing anesthesia for vaginal or cesarean delivery. For vaginal delivery, it is given in the late second stage when the fetus head is on the perineum. It has no effect on maternal or fetal respirations, but may cause temporary hypotension and a post-spinal maternal headache. A spinal block eliminates the bearing down reflex, but proper patient preparation will usually allow for spontaneous delivery. If not, forceps are usually easily applied due to perineal relaxations. Its advantages are simplicity, rapidity of action, high success rate, and a low incidence of maternal and fetal side effects. Contraindications include severe hypovolemia, central nervous system disease, infection at the puncture site, severe hypotension or hypertension, cephalopelvic disproportion, and fear of the procedure. So these are some of the contraindications of the spinal anesthesia. Next is pudendal nerve block. Pudendal block consists of a local anesthetic injected around the pudendal nerve. So this is the pudendal nerve. It is the local anesthetic is injected around the pudendal nerve, which causes perineal analgesia. It is also used in the late second stage of labor, just before the spontaneous or low forceps delivery of the infant. It provides anesthesia for birth and for repair of the episiotomies. It does not alter the maternal or fetal respirations or other body functions, and does not affect uterine contractions. However, it may affect the woman's bearing down reflex and may cause broad ligament hematoma if given early in the second stage of labor. Next is local anesthesia. Local injection of anesthetic agent in the perineum for episiotomy and repair. So wherever we have to do the episiotomy repair, the particular place the nerves are anesthetized with this local anesthetic injection. Next, we'll see about some of the complications with the epidural and the spinal anesthesia. They are hypotension, maternal fever, shivering, pruritus, inadvertent injection into the bloodstream. So before giving injection, we always have to withdraw to see for any blood comes. And if this is not followed, there is a chance for injecting this anesthetic agent into the bloodstream. And next is spinal headache and fetal distress. Next, we'll see about some nursing management during this pharmacological management of the labor, that is epidural, and that is anesthesia or analgesia, whatever we are going to do with the drug. So these are some of the nursing management considerations to be followed. First is assess the maternal blood pressure, pulse, continuous electronic fetal heart rate monitoring, and assess maternal bladder. Assess for orthostatic hypotension, bed rest and recumbent position. Assist while changing position, provide safety and prevent injury. Monitor uterine contractions with pitocin infusion given. So whatever the drug oxytocin or Synto has been ordered, and the drops per minute should be given correctly, and according to that you have to monitor the uterine contractions, whether it is the drug given is effective or not. Otherwise it has to be increased or it has to be decreased according to the uterine contractions. Next is limit the oral intake during labor, because it can sometimes the mother can do vomiting and it can lead to aspirations. and performing frequent pervaginal examination to monitor the progress of the cervical dilatation, effacement, and the station of the fetal head. And next is induction, augmentation, and amniotomy. Along with this pitocin infusion, along with the sympto drip, you can also do the augmentation, that is induction by surgical induction. So this is oxytocin is a medical induction. Surgical inductions like amniotomy, the rupture of membranes, low rupture of membranes, or stripping of the membranes can be done to effectively accelerate the labor. And next is encourage the mother to bear down only when the mother has urge to push. And next is administer regional anesthesia and episiotomy. Assist with the instrumental vaginal delivery or cesarean delivery. So these are some of the nursing management during labor. So till now we have seen about the labor pain. What is the labor pain? The characteristics of the labor pain, the signs of the labor pain, causes of the labor pain, and the perception of the labor pain, and some of the management like pharmacological and non-pharmacological management. In non-pharmacological management, we saw the gate control theory and the acupuncture, acupressure, yoga and meditation, therapeutic touch, transcutaneous electrical nerve stimulation, bathing, showering, warmth, positioning, and hygiene and comfort. These are some of the non-pharmacological pharmacological methods of pain relief during labor. And in pharmacological methods, we saw about the analgesia and sedation and anesthesia. Under anesthesia, we saw many types of anesthesia like local, paracervical anesthesia, pudendal nerve block, spinal anesthesia, epidural, and general anesthesia. So we also saw the nursing consideration. So I hope you all learned about the pain relief during labor. Thank you.